from the laptop.
Thank you.
All right. Can you see my presentation screen?
Yes, sir.
Okay. All right. Cool. So, all right. So the topic for today is CPOE and BCMA. These are high-level concepts. Most of you would not have heard or seen CPOE and BCMA in this part of the world because the implementations of CP and BCMA are very few in emerging markets. Most of it is in the developed world. But then it's important to understand as to what CPOE and BCMA is and why is it so high on the hierarchy in terms of maturity model. So the maturity model that I have followed and implemented at various places is HIMSS EMRM, which is Electronic Medical Record Adoption Model. And it has 7 stages. And in that, it is the 6th stage, which actually has CPOE, BCMA both completely implemented. CPOE is at stage 3, but by the time you get to stage 6, you completely implement it together with BCMA. Any expectations you have from this before I jump into the details so that I will try covering your expectations? No?
Sorry, Raghu.
No, sir. Just the clinical decision support systems also you can explain it. I think that will be covered.
Yeah,
how it works.
Sure. There is a slight difference between clinical decision support and the way CPOE standards are. So CPOE standards are a step above normal clinical decision support systems. But yeah, I'll go into that. Sure. Anything else?
I just want to understand more from the point of view of the Indian context and how this will be applicable here, if at all. Because it's not been mentioned specifically in the NDHP, right? So
Yeah.
how does this fit into our context from an implementation perspective? Is it somewhere down the curve? Abhi nahi aayega. So just in India context will also be helpful.
Okay, I will try that. Sure. Anything else? Okay. So we jump into the details. So this is what I will try to do. Healthcare IT evolution, that is a Gartner model. I don't know how many of you have seen it, but I'll quickly walk you through it. Then Institute of Medicine's report on CPOE. The Leapfrog group, this is the nodal body that sort of created the standard and now is responsible for managing it. Examples of CPOE implementations, and then an evaluation of CPOE and a couple of other things that we'll go into. Starting from the healthcare IT evolution model, this is a Gartner model that was put together. That all the data collection started from from a collector kind of a model where data was being captured by data capture systems. These are transaction one-dimensional systems, which are just sort of typically you might have heard from a lot of people that you put a form into an IT system and all you are going to do is capture the data. So that's a typical data capture system. From a maturity model, it sits very low in the hierarchy. But in India, if you look at it, a lot of these systems are still at play and they're just data capture systems. So they put out a form, they're accepting a certain amount of data in a certain format, and that's it they can do. They can't do anything else. So these are standalone applications and they are transactional, they are one-dimensional in nature. The system matured from there to a department level workflow automation, where this is a document management system. The reliability came in and started saving time because there was a workflow that was built in. So people didn't have to carry files within the department, so to say. So that workflow came in. This became a documenter rather than just a data collector. Enterprise integration is all these systems which are at the entire enterprise level. So the entire organization has the same system or a system that is integrated with each other, or a group of systems that are integrated with each other. And the data can flow across departments, across systems, across people seamlessly. So this is a knowledge-driven system. The clinical pathways are established. There's a disease management protocol that is established. Outcome measurements are there. So all those, so this become like a helper system. If you look at the market today, most of the systems that you see in the market, they are at this stage in India. So, these are enterprise integrated systems. And you will see, vendor lock-ins a lot happening there. Because vendor lock-ins happen because vendors love to have an enterprise class system. Go and tell the customer that I will give you the best of the breed system, but you have to have only one system, only mine system. Only then it is possible that all of them will work together. All the different implementations will work together. If you don't have one single system, then it is not going to work together. So that is the kind of argument they give, and that's the kind of thing that I've seen in the past. Next level is a consumer relationship management kind of it becomes a colleague. So that's when we are talking about web-based portals, personalization coming in. It is protocols which are per doctor or a per clinic, that kind of a personalization coming in. From a patient perspective, personalized medicine begins to take shape, and it is available. So there are logins for everyone. They can log in anywhere and everywhere over the internet, and the system is on the cloud, so to say. And then the highest level is evidence-based medicine. That's where CPOE, data mining, and knowledge base. So this is the bang for the buck. So all these different pieces below the evidence-based medicine are going to contribute towards getting the evidence-based medicine. Now, what is evidence-based medicine? So I'll give you an example. So if a patient with, say, diabetes having deep bone infection is admitted to the hospital, the doctor may like to look at the database or ask the database that tell me all other patients that have had something similar and what worked for them and what did not work for them. What is the antibiotic that worked? What is the protocol that worked? And that is the kind of analysis or point of care analysis that can happen. And this is the evidence that the doctor is looking for, that, is there an evidence for a particular, say, lincomycin? Will lincomycin have any benefit in a patient like that? So this is the kind of evidence that a doctor can look for from the database. Or at a population level, you can ask that, like the current crisis which is going on, that what has worked or what has not worked in similar flus of RNA viruses. So, if you have the database, then you can do that query. If you do not have all that data in the standard format, sort of structured for data mining, then you cannot do that, right? So that is the maturity model. So it becomes a mentor. The system becomes a mentor, so to say, right? So that's the Gartner model. It's not mine. It came from Gartner, and I have adopted it and applied it to healthcare IT. And the Gartner model is across all the industries, and it's not just healthcare. Any question before I move forward? Okay. So, HIMSS analytics. So this is your MRAM model. It's been talked about a lot, and a lot of people sort of rally behind it, and So HIMSS is Healthcare Information Management System Society. It's a very well regarded healthcare IT body in the US, and they came out with this model. And when you go from 0 to 7, um, when you go to the higher levels, that is 6 and 7, stage 6, stage 7. At stage 6, there are only 40 hospitals that have been able to achieve the stage 6, and stage 7 is even fewer than that. So globally, that is, so it's so hard to achieve those levels. And if you look at this, CPOE is sitting at stage 4 with clinical decision support, and BCMA, which is basically technology enabled medication, is sitting at stage 6. So without CPOE, BCMA cannot work. And that is why we say that, the full potential of CPOE is realized only when you implement the BCMA. Any questions on this model before I move forward?
Sir, in India, at what stage are we?
So it's a graded response because Max Healthcare, the implementation that I was leading, that achieved stage 6. So it is one of the 40 hospitals globally that have achieved stage 6. In India, there is no other hospital that has been able to achieve stage 6. Most of the others who have attempted on HIMSS, IMRAM, they have not been able to go beyond stage 4. Stage 4 has also been very difficult. Does that answer your question, Raghav?
Sure. Yes, sir. Sure. Thank you.
Okay. So Max Healthcare is the only one across all the 12 hospitals that achieved stage 6. Apollo Chennai did not get 100% stage 6, but one of their departments has been able to achieve stage 6. Just one department. I don't know which one, but one department.
And when RFP is released, is this a part of the specification in any way, or eventually specifically from the government side in the Indian context?
So nobody has recognized it so far in India, especially from a government perspective. Nobody even knows about it. We tried to bring it to fore in the EHR standards and the NTDA standards. It is mentioned in some of the places as references, but beyond that, nothing.
Okay.
And even in the private sector, because of the, it's more of a browbeating kind of a tool from CIOs that have worked outside India. So they come and tell the vendors that where are you on the MRAM model, and majority of the vendors, they come and say, I'm not even an EMR, I'm an HIS. So they completely chicken out.
And maybe this is a incorrect question, but just ask it anyway. The NHA, the RP that's out and what they're going to build as IT 2.0, any component of that is adopting or is leaning towards adopting any of these kind of standards?
So this is a provider side. What you asked me is the payer side. So payer side standards are different. They do not sort of fit into this.
Okay. And even none of the, okay, fine.
So if it was happening on the payer side and this was applicable, then we would have done that. But so far we haven't been able to reach the level on the provider side what we have been able to do with NHA. Whenever on the provider side we do implementation or a tender or anything at that level, we will bring up the HIMSS IMRAM and make sure that people at least know about it. If there's a conscious decision to not implement or partially implement, that's fine. Let it be a conscious decision. Do you want me to go over all the stages one by one, or this much is enough? You can read through it. If you look at it, the external HIE is at level 7. So that's our pillar 5. Governance, pillar 7. That's why I say governance comes later. That's a maturity model. Once you've had a very strong governance, that means you're at level 7. Disaster recovery. We've spoken a lot about disaster recovery, privacy and security in many of our other sessions. So these are all level 7. When they say complete EMR, that includes all the modules that Priyanka was talking about. Okay. Okay. So in meaningful use, that Obamacare, they have sort of built-in computerized physician order entry and BCMA. So there are standards that were put in for CPOE. The objective was that CPOE for medication, laboratory, radiology orders entered by licensed healthcare professional per state, local, and professional guidelines. And the measures were that at least 60% of the medication orders, at least 30% of laboratory orders, and at least 30% of radiology orders will have to go through CPOE, not manual, not on any other system other than CPOE. So this was a target given to every institution that if you achieve this, then we will, give you the payments or the incentives. Otherwise, we will not. So this is built into the meaningful use that I talked about in my previous session. Any questions? Similarly, electronic medication administration. So automatically track medications from order to administration, which is nothing but BCMA. So the measures are more than 10% of the medication orders go through the entire BCMA cycle. So, the emergency department, they also adopt it during the EHR reporting period. That also is adopted, and where all doses are tracked using EMR. And, so that's that every time the patient gets a dose. It's not that, once a day the patient is given a dose, you follow the process, and the rest of the time you don't follow the process. So that's not acceptable. Okay. Now, what is CPOE and BCMA? What has been seen is that 56% of the medication errors occur at the time of clinical orders. Medical errors can occur anywhere and they need to be prevented. But at the time of giving orders, these are preventable medical errors, and these can be sort of prevented if some intelligent systems are there. But not always you have intelligent systems in place. So you have these, that is the reason the CPOE was born. So I'll tell you in a little bit as to why did CPOE come into being. But it is because of the 56% figure that the entire population woke up in the US and said, "Oh my God! So can we do something about it?" So okay, but then just catching 56% of the errors or preventable medical errors at the order stage is not enough. You need to catch the errors at the dispensing stage, at the administration stage, and then assess it on a regular basis. Okay. So in any other industry, when you look at it, the orders are being given at one place in the organization. When you look at it in a manufacturing kind of a model, In manufacturing, orders are coming through a one channel, and then there is a lag time, and the orders are being sort of serviced, and you can track it as to how much is the lag time and in how much time were you able to fulfill the order. So the order fulfilling system is a different system than the system through which the order is coming. But in healthcare, that doesn't apply because clinicians are ubiquitous. They are everywhere in the hospital, and they're giving orders real time. These orders are being executed almost simultaneously, real time. So, that creates a huge challenge in terms of the accuracy of the orders and the tracking of the orders, the fulfilling of the orders, and so on and so forth. So obviously, errors are bound to happen. But then that is where you need to reduce the errors. And the standards like CPOE come into it.
Sir?
Yeah, go ahead.
When we say orders, we mean like what is the treatment procedure or the prescription or the medicines we are talking about?
Good question. So orders can be any kind of orders. It can be clinical orders that go and get admitted. It can be a lab order, go and get a lab test done. Or it can be a radiology order. I want to see your CT scan, please get it done. Or it can be a prescription order, which is a drug order. So in India, that is where the language is slightly different. In India, most of the time when you say prescription, it means drugs. But technically, that's just a drug order. You have various kinds of different orders, and all of these orders bundled together is a prescription. Globally, that's the definition. In India, however, there's a little bit of a fuzziness there. I won't say it is different, but it's a little fuzzy because nobody has clearly defined as to what is a prescription from a clinician. Because what a clinician does is he picks up the pad in a physical world where there is no electronic system. He picks up a pad, and on the pad he writes all the orders one by one, and they're all jumbled together, and you really can't make out which one is a drug order, which one is a lab order, which one is a radiology order, and which one is a referral. Even if there's a referral, it's all written there. So, so that some bit of work has to go into in India. And I expect the new NMC to sort of work on that and clarify which all orders fit into a typical prescription. Does that answer your question?
Yes, sir. Sorry. Sir, I have also one more doubt, just simple doubt. This CPOE model, is it similar to the e-prescription that we are going with?
So e-prescription object, that's what you're talking about?
Yes, sir.
Okay. So e-prescription object is, again, we have designed it for India. So if you look at our Niti Aayog paper, there is no e-prescription object. It's an e-encounter object.
Yes, sir.
We designed the e-prescription object because India loves the word prescription. And we've kept it fuzzy accordingly. Until NMC comes up and clarifies it, we will keep it that way.
Okay.
Okay. So how does this work? So orders are given by clinicians on a tablet, which is a medical grade tablet. This is a picture of a medical grade tablet. These are special hardwares which can be sanitized. They can undergo a complete, infection control procedure, and nothing happens to them when they are even autoclaved and all that. So that's the tablet, which is a medical grade tablet. A clinician can carry it around and there are drop downs and procedures that the orders can be selected, and these orders can be given. So for example, if there's a drug order, so it's given on this tablet by the physician, and then automatically the system carries it to the pharmacy. So once you implement this, there is no general duty assistant or a nurse or anybody who will have to carry this to the pharmacy. As soon as the physician enters it, it's gone to the pharmacy straight away. Okay. In the pharmacy, what happens is the pharmacist looks at it that, okay, this is the order that has come. So he has to dispense. So he will print a barcode. He will put the drugs into a sachet and will print a barcode and put the barcode onto the sachet or onto the strip itself. That's an India thing. But in developed markets, that's not allowed. What you have to do is put the drugs into bottles, and those bottles will have to be stuck with these barcodes. So in India, what happens is we have these strips, and the dispensing is different from the way it is done in the West. So we allow that, put it into a sachet and put a barcode on the sachet. But that's not the ideal way. When you go and see an ideal implementation, it will be the drugs being put into bottles, and it could be liquids, it could be tablets, it could be injectables, whatever. It will be put into bottles, and the label on the bottle will be a barcode printed label. So the pharmacist will print it, put it on the bottle, and then scan it. So the scanner, so there's a barcode scanner with the pharmacist. He will scan it, and once he scans it, the system records that the order that was given by the doctor is the order that has been dispensed. If there is any error, it will flag and it will beep, not allowed, not allowed, not allowed. So the system is automatically checking that, the doctor, whatever the physician has given, that is the one that the pharmacist is dispensing. However, there is flexibility given to the pharmacist to do a replacement. And the replacement can be that instead of one brand, he can give another brand. Or in the same category of the drug, instead of one molecule, he can give another molecule. And that's a flexibility that is given to the pharmacist. By law, a pharmacist is allowed to do that. So that the system, CPOE system, allows you to do that. The BCMA system has these flexibility built in. Any question on that?
No, sir.
Okay. So after putting the label, after the scanning, now this bottle or the sachet is loaded into a cart, which is called a medication cart. Now, instead of the earlier method where the medicines will be bundled and carried. So in a mature BCMA implemented hospital, it is carried in a medication cart. This medication cart has all the configurations. So this is also hooked to the same system, and you can see that it's a computer on wheels. So there is a computer also on that, which knows as to which part of the cart is to go to which nursing station. It's completely labeled and numbered. Okay. So the cart is an intelligent cart. It knows that which medicine is for which nursing station. Somebody will come and sort of take the cart to the various nursing stations, and automatically the cart will say this particular packet for this nursing station, and the nurse can take it out and use it, or okay. That's how this medication cart works. There are some automated medication carts also, where a person doesn't have to take it around. The pharmacist can load it and let it go. It will automatically, like a robo, roll around in the hospital, go to the respective nursing station, beep, and the nurse can take out the respective one. There's another way of doing it, and that is pneumatic chutes. So there are hospitals that have pneumatic chutes. So the pharmacist can load it into a pneumatic chute. You can see that picture on the right. A nurse is taking it out from the pneumatic chute. So pharmacist will load it into the pneumatic chute and press the button saying, okay, this particular nursing station, or there are certain more mature pneumatic chute that can read the barcode label and it will carry it to the respective nursing station. The nurse takes it out, and once the nurse takes out the packet, scans it from a barcode scanner again. When the barcode scanner scans it, the system again validates that this is the medication that was prescribed by the physician and the quantity is the right quantity and all that. So if it is not matching, it will beep, 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 not allowed, not allowed, not allowed. Any questions? At the time of medication administration, the nurse will carry it to the patient. Nurse will scan the wristband, which also has a barcode, the wristband of the patient, and the system will match the wristband with the identifier of the patient for which the order was given. Only then the system will allow the nurse to do the administration of the medicine. And before the medicine is administered, again, there's a scanning of the packet or the vial or the sachet or the strip or the bottle, whatever may be the case, that has to be scanned again. And only then the nurse should do the administration of the drug. If any of these steps are not followed, there is a clear legal liability fixed on the person who administered the drug. So as a result, you're pretty much eliminating all the errors that could have happened from the stage of drug orders all the way to administration and beyond. Any questions? So here is a scenario. Now, if the patient has an allergy, physician orders an alternative medication. The pharmacist doesn't know, and the pharmacist dispenses the previous medication. Nurse also doesn't check that there is an allergy that has been reported and should not be giving this old medication, and goes and administers it. What will happen? It will be a massive allergic shock, right? It could be an anaphylactic shock. You could lose the patient. And these kind of things happen. They happen quite often. And, this is a scenario where you do not have a CPOE BCMA system built in, right? Or you may have CPOE BCMA, but it is broken between different systems. The pharmacist is using a different system, nurse is using a different system, the doctor is using a different system, and they're not integrated using the same standards. Why do we keep harping on standards? If they're all integrated using APIs, but they're not integrated using APIs that are built on the same standard, then the APIs at the technical level will communicate with each other, but semantically, they're not making sense to each other. As a result, the scenario that is in front of you will happen. So what will happen is additional days in hospitals, there will be litigation costs, there could be patient death, and whatever else. So in a disparate system, this is what happens. However, in an integrated enterprise where you have standards-based integration, what will happen? The system will beep, just the journey that I showed you, and every stage the system is checking that you are administering what the doctor or the physician ordered. So the system is intelligent. So in CPOE and BCMA together, it's basically an intelligent system that is looking over the shoulder of all clinicians and telling that, okay, have you sort of double checked it? I have double checked it, but if there is something that is missing, you may want to double check. So it's sort of, a mentor that is looking over the shoulder and saying, I hope you are going on the right track. Why did this all happen? This happened because there's an Institute of Medicine in the US. They published a study called To Err is Human. What it said was that 44,000 to 98,000 people die every year in the US because of preventable medical errors. And these are wrong medication, double medication, unnecessary medication. So all those things, or medication prescription is one, administered as something else, or at the time of dispensing, they got mixed up. So all those things, preventable medical errors. Yeah. So this is what the study was. Now this is a US study. If you look at India, we don't have any such study. So what is the error rate in India? We don't even know. Obviously, given our systems, it's much, much worse. That is when the Leapfrog group was formed. The Leapfrog group was created by large employers like Microsoft, Boeing, Ford, and a couple of others. So these large employers, so they all got together and created Leapfrog group. This Leapfrog group is a patient safety group because all these employers said that if so many patients are dying because of preventable medical errors, this is a patient safety issue. And this is a loss to us because if you were to go to Seattle, it is said that, you are either working for Boeing or you're working for Microsoft, or you're related to somebody who's working there. So it's, pretty much that area's entire economy is controlled by Boeing and Microsoft. If you were to go to Michigan, it's all Ford. Ford runs pretty much everything. If you were to go down south, so Kaiser Permanente, is a very large organization. So everything, whether you talk about payer, provider, or ancillary, everything is owned by Kaiser. So you have those sort of large behemoths in the US, and that is the reason they all got together and said, we need to do something for patient safety. There are no standards. And I'm talking about this is way back. I think it was in 2000 when it happened. And then, by about 2003, this was well established. So that's the Leapfrog Group logo. So these are more details about the standard that they put together. EHR standards, CPOE standards are just, few of those, patient safety. But then, they went into more details about what are the other things that you can do for patient safety. And if somebody is interested, you can go to the Leapfrog Group website and read it. Why is CPOE required? It's pretty clear that, this is on the left-hand side. This is what you find in most of your hospitals here. And obviously, it can be misread and the errors are possible. On the right-hand side, the chances of errors are less. And if you build intelligence into that system, the errors are still less. Okay, let me step back a little bit. Why am I saying the errors will be still less? See, why did somebody was asking in the morning, I think it was Ved, that MDDS, how is it going to be used and why was it going to be used? And these are not just Ved, many people have asked me those questions as to why. The reason is simple, that if you do not have the same semantics across the board, whatever you may do from a technology perspective, it will fail. CPOE cannot be done. BCMA cannot be done. And then if CPOE, BCMA cannot be done, it's a patient safety issue. In the US, 98,000 people are dying because of that before CPOE happened. In India, it's much, much worse. right? So it's pretty clear why do we need to do it. So these are some more details on what the CPOE leapfrog group says. It says that, physicians enter at least 75% of the medication orders through computer systems that include prescribing error prevention software. I'll go into some of those more details as we go forward. So some examples of CPOE. So this is a screenshot that is taken. Now, what does this say? So it's a drug duplication. So from the same category of drug, the drug has, two different drugs have been prescribed twice. So the system has intelligence where it is able to pick it up and say that, you're prescribing pretty much the same drug, even though the name may be different, but it's the same category. So please don't do that. So system will flag it. Why do I always keep talking about Cerner? Because Cerner is a master of this game. So Cerner has all these intelligence built into the system. When they go and implement it, it can come, all this entire knowledge base comes along. So if there's an allergy to hydromorphone, so the system will flag it and say, no, you can't sort of do this because this patient is allergic. If two different drugs, there is a drug-drug interaction, again, the system will say that, you're prescribing one, so obviously you're not allowed to prescribe the other. So morphine and atenolol should not be prescribed together. Both of them are going to reduce the pulse rate, and that's not a good thing to be. Are you with me, all of you? Or is it a monologue? Am I just...
No, sir, we are. Yes.
Okay. Drug-food interaction. So there are a lot of intelligence built into drug food. So for example, if there is a patient on digoxin or warfarin, and the patient's, potassium levels is something that starts dropping, and there is a food that which is vitamin K rich. So there is a food and drug interaction, and so many times we will say that don't sort of, or you need not have the kitchen integrated into the system. Well, the dietitian has to integrate its orders into clinical orders because it has a huge repercussion on chronic diseases. Somebody who shouldn't be having calcium has more calcium, you can lose the patient. So here are a list of the things that or rules those CPOE make sure they are in place. These are 14 category of rules. So therapeutic duplication, allergies, contraindicated route of administration, that for example gentamicin, that's only to be given as injectables, and somebody gives it orally, patient will die. Drug and drug food interactions, I gave you some examples of that. Contraindications, dose limits. So there is something that has exceeded the dose, then the system will say, please don't prescribe more. In terms of dose limits based on age, gender, and so many other factors. So the system has that intelligence. It will flag and say, please don't do this. And so many other things like laboratory studies. Yeah. So if the patient is on digoxin and the potassium level starts falling, then the system will flag it and say, well, the patient's potassium levels are falling. Please do something about it. Otherwise, you lose your patient. So these are very intelligent systems. When they are implemented, they are across the board. It's not just, so the doctor has to act on it. And the system will fix liability on the doctor if the doctor doesn't act on it. in the court of law, then there is no escape. Any question before I move forward?
Yes, sir. Sir, so all these things can just be done taking the general history of the patient, like how much dose it has to be given, what are the allergies. Just from the history, the computer will uh, detect it.
It's not just the history that is taken, but it is PHR or EHR, which is cradle to grave. So all the past history, including all the past treatments, all the medical record, and the system reads all of that and builds its case.
So they have to be there. Right? So they are the prerequisite, as you can, in one country.
Correct. And that is the reason we are pushing for the case for PHR, right?
Yes, sir. Yes, sir.
And all of these PHRs have to be in the standard format, so they all can be read by the system. Imagine if all the different input histories or past records are coming in different formats and the system cannot read it, then obviously all the thing that I'm talking about, CPOE, BCM, that's not possible. It's impossible. So India context, as Anahita said, when we took over Max, they had a plethora of different systems. And, Krishan was there, Komal was there. So 2 people from this team were there with me at that point in time. Priyanka was there, but then, she was, I think, an intern at that point in time. So you had to deal with a whole lot of different systems that we inherited. Each system doing its own thing and not really integrated with each other. Each one, the semantic interoperability, we just keep talking about again and again, like a broken record. So we had all those problems. None of the systems would talk to each other. They were not built to talk to each other. And we had flat 2 years to make it happen. So what we did was we ripped off all the systems. We re-engineered every damn system. We made sure each system talks to each other on standards and then built CPOE and BCM on top of it. So when I started, people used to say, साहब this is India, आप क्या बोल रहे हो, आप यूएसए से आ गए तो आपको लगता है यहाँ हो जाएगा. मैंने कहा भैया मेरे पास 2 साल है, मैं तो करके उठूंगा. So so obviously we delivered in 2 years flat.
And sir, how did you tackle the problem of EHR or EHR?
So it was 12 hospitals. At that time, there were 8 and 4 new being built. Geographically disparate from each other. And we had to integrate everything. So what we did was we built it on a private cloud, and we created a private cloud on the Dell data center. So this Dell data center was in Noida, and there was a disaster recovery site for that in Bangalore, which was a replica of this. And an MPLS network was connecting all the hospitals. So, before this was implemented, whenever you had to set up a new hospital, you had to plan for the IT. So after implementation of this, we took it to a point where you didn't have to plan for IT. You just had to plan for the physical infrastructure, the routers and switches in the hospital, the internal network hardware to be in place. And then you had to go and configure it in your data center, and you're good to go. So you didn't need anything else. So the new 4 hospitals, when they came up, it was just a switch on. Well, it was supposed to be a switch on, of course. By that time, the team left, and Max went through a little bit of a problem, internal problem. But from design perspective, no issues. So EHR was by design. And even if you were to put any other system in place, new systems, they had to follow the same standards that were already there, institutionalized. So there was a single ID for all patients. So any patient going from hospital, the system recognition came to Delhi, or a Delhi system recognition. System had so EHR by design. Okay, and then doctors. So there were some doctors who were on full-time role. There were doctors who were visiting consultants. We had IDs of everybody. Any new visiting consultant who did not have an ID could not work. Simple. Period. HR policy. You have to come through the system. And it was nearly paperless hospital. Adoption, we were able to achieve 95% adoption. Of course, we went through a whole lot of problems. There was a time when 300 nurses came to me and said, we are resigning. We just can't do this. And then there were many other issues. So we went through all that. And then, there was one very interesting one and related to CPOE, I can tell you. So before CPOE came in, there were about 200 odd GDAs, general duty assistants, that used to run with the files. So after there's no files, right? So you don't need GDAs. Now these GDAs went and did a dharna. What is going to happen to us? And the hospital administration was also like, "Yaar, ab iska kya kare?" But then the point that I put in front of everybody was, with BCMA, you're going to need more people than what you had earlier. So you actually don't have to lay off people. You just have to retrain and redeploy. Because for every barcode that has to be printed, it has to be printed, it has to be labeled, it has to be carried. So instead of carrying files, now these guys will have to be at the pharmacy and carry the medicines to the nursing station. So, and that was a alternative solution to those medication cards I talked about. In India, medication cards were not available. So I had to figure out an alternative solution. Does that answer your question, Raghav?
Yes, sir, surely. Thank you, sir.
Any other question?
Not from me.
Okay. So there's also an information overload that is possible. So all these alerts that will keep coming, right? Doctor is prescribing something and the system is giving an alert, don't do this, don't do that. Have you seen this? Have you forgotten that? That can also be an information overload. The doctor, the nurse, the clinician, the pharmacist, they can all get, fed up and say, just shut up. They can just tell the system, shut up. So that's also possible. And we've seen that happening. So, when at one point in time, what I did was, there were support people on every floor in the hospitals. So I just took it away. So there were total 40, 50 people per hospital. And I said, this is a huge cost. Okay. So one fine day I said, all right, I'm going to withdraw all of them. And I just withdrew everybody. And I put a call center at the back saying, if anybody needs help, call the call center. Initially, all of these guys, they said, too many alerts coming to me and, I'm not going to work with this and all. And then, there were nurses who said, I'm not going to call the call center because in 3 minutes that I'm explaining my problem to the call center, I might go and see a patient. So all those things settled down because they realized that the total benefits are larger than the change. And it took me a while. It took me about 6 months of sleepless nights and getting all the brickbats and being beaten, black and blue by everybody. That, what the hell have you done to our system? What have you done to our hospital? What have you done to our patients? Are going to run away. We are going to be jobless. The hospital is going to be shut down and blah, blah, blah. None of that happened. After 6 months, everybody adjusted to the processes. But then, what I'm saying is don't overload. So your clinicians are also humans and you have to make sure that you're not overloading them with too many messages and too many information. Here are some examples of failures from the US. Of course, US is very big on CPOE and BCMA. This is University of Virginia. So here, the hospital attempted to introduce the CPOE. There were some technical issues, but majorly it was the human issues which basically derailed it. And all the humans said, no, this is not going to work for me. So it was basically a change management issue than a technology issue. Is another Cedar Sinai Hospital. Cedar Sinai actually went through another sort of a problem. They said it was slow, and the workflows are taking more time. So if I was taking 10 minutes per patient, now I'm taking 20 minutes per patient. That happens because when you change the workflow, when you change the process, it takes a while for the physicians to get used to it, and the productivity comes back, but initially the productivity gets hit. And in a scenario in like for a hospital in India, I won't name it, tried doing CPOE BCMN, it backfired big time for them because majority of the doctors were independent consultants. They were not on their rolls. So when the productivity got hit, it also hit the amount of money they were taking back home every month. So they said, this is not acceptable. I was making, 2 lakh rupee till last month, and now I am able to make 1 lakh 20. This is not acceptable. So they had to shut it down. What they did not realize was that had they kept it on, the same doctor would have been making 3 lakh instead of 2 lakh. But they didn't have that tenacity. Adoption benefits. David Bates, he did a study in Boston Hospital. He said that you are able to reduce the length of stay, and you're able to reduce the total cost. You're able to reduce the litigation cost, and so on and so forth. So a lot of these things came out of Dr. Bates' studies. This was the application that I designed. And somebody was asking me about black box testing in the morning. So this is a black box testing. What it does is it tells you, it treats a hospital as a black box. So it tells that this is an input order. So input that order and then measures the output. Let's see what the output comes. If your system is working and it is CPOE compliant, then it will give the output that is acceptable output. Otherwise, your system fails. Challenges. So these challenges are coming from Obamacare. In Obamacare, they said incentives paid for implementation, not for the product. So what happened is a lot of these hospitals, they said, I have the product, so give me the incentive. So Obamacare said, no. Meaningful use doesn't mean that you just buy the product. You also have to implement it. And as I said in the morning, implementation takes a couple of years. So it's not that you can do it very easily. It does take time. Different systems, outpatient orders, inpatient orders, different systems. How will you integrate it? You need the denominator, right? The total number of orders. So if these are different systems, how will you get the denominator? That's a problem. Group of hospitals may have different EMRs. So again, as I was saying, they are systems which don't talk to each other. Even if they talk to each other, they don't talk to each other on standards. So then how do you get the things right? There are direct orders. People who will just go to the lab and give a direct order. So it's not in the system. It's there in the lab system, but it's not there in the larger system. So then how do you sort of reconcile? Similarly with radiology. And then additional orders while doing the test or the imaging, the radiologist then and there gives a additional order, and that doesn't go through the system, that just gets executed. So then it's again not in the larger system, right? So these are challenges, practical challenges. Another set of challenges, integration issues, data silos, data loss. Even if you integrate and it is on standards, but there can still be data loss. For example, in public health, you have HMIS saying HB less than 7 as a data element. Now, HB less than 7 data element, how do you translate it into another system that is a standard-based system which has lab test equal to HB and values equal to a range? Now, how will these two things match? It's very hard, and these are the kind of issues: hardware issues, Wi-Fi's, and scanner issues. In BCMA, you have to scan at every stage, and if the Wi-Fi is not working, so what will happen? You did scan, but it did not get recorded into the system. System did not give you a response, and obviously, when the drug either cannot move forward, or if it has moved forward, say from a dispensing to a nurse, and the nurse is not able to get the data because the sync up did not happen because of Wi-Fi. So so those kind of issues, real issues. New nurse not yet trained. So this happens all the time. You have 35% attrition of nurses everywhere, and nurses have to be constantly trained on new systems. And if she's new to the system and she's not very well trained, you have a problem. In emergency cases, retrospective catch-up. In emergency, you do not enforce orders. What you say is, go ahead, save the patient, come back and enter into the system, and then override. So you come and enter orders into the system after you have taken care of the patient. Now, in the meanwhile, a lot of things would have gone, say, samples taken, sent to the lab, samples taken, sent to the radiology, and whatever else. So now they have to be executed, but orders have not been put into the system at all. So how will they be executed? So these are practical challenges. Patient ID bands are cut off. Patient is feeling irritated, usne utar diya. Miscoded medication print karte time proper print nahi hua. So or sachet or the bottle came empty, usme dawai nahi hai. It was delivered without scanning. Somebody delivered it, scan hua hi nahi and deliver ho gaya. Damaged barcodes, barcode read ही नहीं हो रहा, आप क्या करोगे? Override alerts. So there was an alert, but either the person was new to the system or the person was too irritated. मेरे 36 घंटे की ड्यूटी हो गई, छोड़ यार. So alert override कर दिया. Alert को override कर दिया, तो obviously on the other side you'll have problem. And then cost reduction. So this is a huge issue. Okay. Now, every time I've had problems with CFOs will always come and say, मैं क्यों करूँ ये? What is it saving for me? Where is the money that is being saved? So my argument to all the CFOs has been that if you're going on the correct side of the road and you have avoided accidents, what is the value of the money that you have already saved by not causing those accidents? Imagine if you had caused those accidents, there would have been a value, right? There would have been a expense. Now that expense didn't happen just because you're on the correct side of the road. Now, something that didn't happen, how do you put a value to that? So it's a hygiene issue. It's not something that you need to justify. It's the same thing as के नहाते हुए मैं साबुन क्यों लगाऊं? Justify करो. It's a hygiene thing. You just have to do it. If you don't do it, you will realize the cost, but then the cost will come over time, and that's not something that you want. So it's an ongoing debate on ROI. That's just me, my picture in a jungle. That's another picture I'd taken built to last. So that's it. I stop at that. Any questions? I'm happy to have a discussion because this topic is not easy. We can use the rest of the time for a discussion. Happy to have a free flowing discussion on this. Go ahead.
Sir, just a basic question about how is it different? It's very different, but how do the clinical decision support system, like I asked in the beginning, so what is it, their processes, and how does it work, and how will be different? How is this different from that?
So it's not different. So clinical decision support works on a set of rules, and CPOE is giving you those set of rules. So if you don't have CPOE, you will end up writing your own rules for clinical decision support, or you will use a self-learning system like an AI system that will build its own rules, right? So that's all it is. I mean, CPOE is giving you those set of rules, and you can use those rules, build it into your rule-based engine for clinical decision support. So it's not different.
Sure, sir.
Yeah, but of course, when you come to artificial intelligence, it does create a new angle that CPOE gave you a set of rules to start with, but then after that, AI will take over, and we still don't know whether AI will make the right decisions, and can we really use AI for something like this? So you can use AI, you can use CPOE to train the AI, but can you trust the AI? Is something time will tell. I haven't seen any report which has gone that far. Any other question I can answer?
I was saying earlier, also from a stakeholder perspective, if we are to slide this into conversations, uh, more about taking this a step forward in Indian context. How do we slide into conversations, whether it is at the ministry or the NIC, or is that something we should not even think of doing right now?
No, you are absolutely spot on. In fact, the steps have already been taken in this direction. So the EHR standard, the MDDS standard, and the PHR definition that has been given in NDHB is all towards this.
Yeah.
All of that has been done keeping CPOE, BCMA in mind. Because those are the building blocks. Without those, you just can't achieve this.
Okay.
So that is why I always keep telling people that Max Healthcare achieved something in India which India as a country has not realized what they achieved.
And should we include this in our capacity building curriculum topics? It's not specifically there.
Yeah, it's not specifically there. It's a higher level topic. In our capacity building, I think if people can understand simple facts about EHR, MDDS, PHR, EHR standards, and how do you roll it up to make it a PHR, that's good enough for now. I mean, the maturity level of the audience is not there to understand these higher level concepts. Maybe EMR adoption model, the HIMSS adoption model, is something you can keep. But having the details of CPOE, maybe this is an advanced level session for capacity building. Once everybody's gone through the basics, then you bring them for an advanced session on CPOE BCMA.
Sure. Okay.
So you all have met a gentleman called JP Dwivedi. He is the CIO of Rajiv Gandhi Cancer Institute. And then there's another person called Dr. Rajesh Gupta. and many of you have met him also. So these were the two gentlemen who were responsible for making CPOE and BCMA happen in Max. Pretty much the only implementation so far in India. From an HIS perspective, it was Komal, but that was back and forth between registration and billing and everything else. So we had to do HL7 integration. Both the systems were not built for HL7. And we had to build HL7 into it. We had to re-engineer those systems and make sure. So at one point in time, we had challenges that one message was flowing from one side, but it was getting stuck in the queue. And in the meantime, something else was getting executed. So we had all those challenges. I saw a very beautiful implementation of BCMA CPOE implementation in Jeddah in Saudi Arabia. This was with a hospital called IMC. And this hospital is 97% compliant to JCI standards. And JCI also sort of has CPOE and BCMA built into it. So that's the place where I saw single unit dosing, prescription, single unit dispensing, and single unit administration. What that means is that if a patient has to be given one drug, one dose, for every dose, there'll be a separate prescription. And it'll be a real-time delivery of the drug coming to the patient. So I saw that very beautifully done there. And they have all these carts that I mentioned. So the medicine carts and the pneumatic chutes. So they have both of those. If anybody wants to see pneumatic chutes, you can probably go to a hospital called Kim's Hospital in Coimbatore. The entire hospital runs on pneumatic chutes. Okay, if there are no more questions, we'll stop at this, and we will revisit our sessions tomorrow.